Afternoon. You can enjoy your food and drink, relax, and let's talk about diabetes and ketoacidosis. It's diabetic ketoacidosis. In short, it's called DKA. So, do you know what are the complications of diabetes? Anyone can raise your hand or can speak it loud? Any of you? Any volunteer? Yep. So there are some chronic complications and there are some acute complications. So chronic complications are macrovascular and microvascular. Macrovascular complications are like stroke, heart attack, like myocardial infarction and peripheral vascular disease. In microvascular complication includes retinopathy, nephropathy, and neuropathy. These are the chronic complications. And if you see, if there are some acute complications, it includes mostly diabetic ketoacidosis, hyperglycemic hyperosmolar state, that is called HHS, and another one is hypoglycemia. That's the mainly complication of the treatment. The macrovascular complications like a stroke, MI, and this can be acute as well. Process is chronic, but the complication is very acute. Okay. So diabetic ketoacidosis usually associated with type 1 diabetes mellitus because if you look at the pathogenesis, it's likely due to absolute or relative lack of insulin in the body. So it's usually associated with type 1 diabetes mellitus, younger patients. It can also occur in diabetes type 2 patients if they're in extreme stress like serious infection, trauma, cardiovascular or other emergencies. Less often, it can be presented as type 2 diabetes, manifestation of type 2 diabetes as ketosis-prone diabetes mellitus. These are these are older population, especially adults, known to have, prone to have ketosis, is not type 1 diabetes, is not type 2, is ketosis-prone diabetes mellitus. In some authors, they call it like type 1.5 diabetes mellitus is because of the cause is mainly beta cell dysfunction. So how do we confirm diabetes? There's an easier way to confirm diagnosis. So if the patient is symptomatic, like osmotic symptoms like polyuria, polydipsia, and polyphagia, we can do the test. We can do the random blood glucose. We can do a fasting blood glucose, or we can do the oral glucose tolerance test. So plasma glucose is random sample or 2 hours after 75 gram glucose load. If it is 11.1 or more, it's called diabetes. If it's more than 11, random sample, diabetes. If the fasting plasma glucose is 7 or more, it's diabetes. And a nice guideline, you can see the HbA1c criteria is 48 millimole per mole. If you check the percentage, it's 6.5%. Okay? In a symptomatic patient, the 2 diagnostic tests are required to confirm the diabetes. The second test should be the same as the first one to avoid confusion. For example, if you do the OGTT, if the patient is asymptomatic, then you have to repeat the OGTT in like 6 weeks. If you do HbA1c, you have to repeat the HbA1c. That means you need to repeat the test if the patient is asymptomatic. If the patient is symptomatic, you can do only one test. That's enough to diagnose diabetes. So these are the ketone bodies and chemically how they look like. So acetoacetate, beta hydroxybutyrate, and acetone, these are the ketone bodies. These are the end product of fat. So these are the pathogenesis, how it happens, diabetic ketoacidosis. So if there is deficiency of insulin, absolute or relative lack of insulin in the body, there's counteracting hormones that's also called stress hormones like glucagon, like glucocorticoids, mineralocorticoids. They are increased in amount, so there will be increased glycogenolysis. That means storage of glucose will be break down, increased glucose in the blood, and neoglucogenesis or gluconeogenesis. That means synthesis of glucose from non-carbohydrate source, and it will increase the blood glucose. And if the blood glucose is high, it will cause osmotic diuresis, resulting polyuria, so increased loss of water and salt in the urine, it will make the patient dehydrated and ultimately hypotensive and develop AKI. The symptom is oliguria and uria. Okay, so on the other hand, if there is a lack of insulin in the body, the one of the function of insulin is suppress lipolysis. If there is a lack of insulin, there is increased lipolysis, so there is a breakdown of fat, the adipose tissue, and release of fatty acid from the adipose tissue increases free fatty acid glycerol to the liver, and the ketogenesis started in the liver, and it causes increased acetone and beta-hydroxybutyrate in the blood. So acidosis causes hydrogen ion in the blood, causes vasodilation, causing hypotension, dehydration causing hypotension. So the end result is hypotension, oliguria, and the patient's symptom initially was osmotic, like polyuria, polydipsia, and polyphagia. On the other hand, if there's increased amount of aldosterone or mineralocorticoids in the body, it retains the sodium, and resulting hyponatremia a bit, and it causes loss of potassium through urine, causes hypokalemia as well. So in patient with DKA, you will find shortness of breath because of metabolic breathing. It also called Kussmaul breathing, to wash out the carbon dioxide to compensate metabolic acidosis. Sometimes you will find acetone smell is a musty, sweet smell in the breath, and it also affects the nerve endings of the stomach and causes slow gastric emptying, causing abdominal pain. Okay, so the main pathogenesis is absolute or relative lack of insulin. So what happens in DKA patient? The loss of fluid and electrolyte. So average loss in a 70-year-old adult male in moderate severe DKA, water loss is approximately 6 liter, sodium 500 milliequivalent, chloride 400 milliequivalent, and potassium is 350 milliequivalent. These are the apparent loss of fluid and electrolytes. So if you keep that in your mind when you are managing patient of DKA, you know how to give fluid to this patient and electrolytes, replace the electrolytes. Okay, so what are the key steps of management? Number one, you have to diagnose very promptly, and you have to manage intensively. These are very, very important steps. Okay, so how do you diagnose DKA? It's very easy. So the patient comes to you with the established diagnosis of diabetes, or is a new diagnosis. You check the capillary blood sugar, it is 11.1 or more, and then after that you check ketone in the strip or in the blood, it is 3 millimole per liter or more. You check VBG. The VBG is acidosis, that means the pH is 7.3, less than 7.3, and the bicarbonate is less than 15. It checks all the boxes, is DKA. So it's like a mathematics. If the patient comes with you hyperglycemia, you do a VBG, you check ketone, you'll get your diagnosis. So bicarbonate less than 15, venous pH less than 7.3, ketone 3 millimole or more, and blood sugar 11.1 or more. Diabetic ketoacidosis is very clear. Okay? Okay, sometimes patient present with DKA and hyperosmolar state overlap. So HHS, that is hyperglycemic hyperosmolar state, is commonly happen to the patient with type 2 diabetes. They have got some insulin in the body, but not sufficient to meet the requirement. So in that case, you need to calculate the osmolarity. So I will show you later how to calculate the osmolarity. If the sodium is high, if you check the electrolytes of the patient, if the sodium is high and the blood glucose is more than 30, you would suspect there may be overlap between the DKA and hyperosmolar state. So when you are going to manage the patient, sometimes you'll get some patient with uncontrolled diabetes, like blood sugar is high, 25 or 20, there is a ketone in protein, but there's no acidosis, so we can manage the patient with only the fluid. IV insulin might not require. That causes diabetes, uncontrolled diabetes with ketonuria only, no acidosis. Okay, there's a difference. And another entity is euglycemic ketoacidosis, especially in type 2 diabetes mellitus, who are taking, I think it's a mistake, is sodium glucose cotransporter 2 inhibitor, dapagliflozin and empagliflozin, who are taking these medications. It causes glycosuria, release of loss of glucose in urine. So this type of patient comes to you with normal blood sugar level with ketoacidosis. Okay, what are the symptoms of DKA? So mainly, I told you before, is the osmotic symptoms like polyuria, polydipsia, and polyphagia with weight loss, tiredness, lethargy. Some patient will come to you with nausea, vomiting, abdominal pain, shortness of breath, Kushmal breathing. So if any patient comes to you with shortness of breath, there is no respiratory finding, chest X is clear, there will be two main reasons. One is pulmonary embolism, another is metabolic acidosis without any chest finding. Okay, so dehydration, headache, hypotension because of dehydration, and tachycardia. Sometimes the patient present with reduced DCS, especially if the patient is a child or children, it's because of the cerebral edema. It can happen, and oliguria is the end result of AKI or inuria. Okay, so you need to see if any patient comes to you with the DKA, you need to see what are the precipitating factors. The number one precipitating factor is an infection, because if there is any infection or any stress in the body, it releases the counter-insulin hormone like glucocorticoids, catecholamines, epinephrine, norepinephrine in the body, and it releases, it causes increased glucose in the blood as shown in the previous slides. So look for any infection like chest infection, urinary tract, cellulitis. You need to ask the patient or the attendants about the symptoms of like cough, fever, shortness of breath, burning in the urine, lower abdominal pain, any cellulitis or any acute abdomen. You need to rule out before you start treating the patient. Okay, so the reason behind this, failure to increase the insulin dose due to stress response. So they may need more insulin to counter the glucogenic hormones. Okay, so another reason in type 1 diabetes mellitus is a missed insulin. In some patients, they are very young, so they want to take the insulin. Sometimes they they don't take the insulin and comes to us with this kind of presentation of DKA. Sometimes they stop it by themselves because of the instruction that if you're not eating and drinking or you're having diarrhea, stop the insulin for a while and then restart, and sometimes they forget to restart the insulin. It happens always. So poor compliance, omission of insulin, and some patient with type 1 diabetes mellitus has got eating disorder like anorexia nervosa and bulimia nervosa. They have fear of weight gain due to insulin because insulin causes weight gain. They just don't want to take it. And it's also associated with cocaine abuse in recurrent diabetic ketoacidosis. There is a relation with the cocaine use as well. Okay, so as I said, in acute condition like in type 2 diabetes mellitus like MI and stroke can also give you diabetic ketoacidosis. So another one is first presentation with complication in type 2 is not very common. So that's why if any elder patient like more than 30 years of age or more than 45, you need to ask about the osmotic symptoms, family history of diabetes, weight changes, ethnic origins, and you can request HbA1c to see if he is diabetic from before. Okay, so ketosis-prone diabetes mellitus in adult, as I said before, euglycemic decay, you know about the medications like dapagliflozin and empagliflozin is associated with glycosuria, with euglycemic DKA, glucose level is normal, but there is acidosis and ketonuria. And there are some drug medication you need to see which can cause high glucose, like steroid, thiazides, and atypical antipsychotic agents like olanzapine, clozapine, etc. Okay, so when to refer the patient to the critical care department? So if one or more of the following applies, you need to refer the patient to the critical care department for HDU, better monitoring. So if the pH, the venous pH is less than 7.1, potassium in a very early potassium is 3.5, or resistant hypokalemia, you are treating the hypokalemia, but you cannot manage the hypokalemia. You need to give more doses of potassium, more concentrated doses, so maybe you need a CV line to give the potassium. So you need to refer the patient to ITU. If it is hyperosmolar, like sodium is more than 160, serum bicarbonate is less than 5, that means severe acidosis. Base excess is high, that also means severe acidosis. Pregnant, very significant comorbidities like diabetes, hypertension, or any other diseases. And ketone is very high, that means more than 6. If the GCS is reduced, like less than 12, sepsis, hypotension despite initial fluid resuscitation, in respiratory failure, like desaturating less than 90% in room air, or severe AKI, anuric for more than 3 hours or more. You need to do the bladder scan to see if there is any urine there, do catheter, and after that, if there is no urine there, refer the patient to ITU. He may need dialysis, and CNS depression. Okay, so you know the criteria for diabetic ketoacidosis. Number 1, I said blood sugar 11.1 or more. Number 2, there is a ketonuria, that means blood ketone will be 3 millimolar or more. Number 3, if you do venous pH, it will be less than 7.3, and bicarb is less than 15. So you got your diagnosis. So how do you want to manage this? So you have to ask about the precipitant factor. It's done already. So fluid management is very important, and is a very important slide, this one. So check the systolic blood pressure. The blood pressure is, if the blood pressure is less than 90 millimeter of mercury, give the first bag of fluid over 15 to 20 minutes. If the systolic is more than 90, you can give it over 1 hour. So first bag should be normal saline given over 1 hour. Okay, so normal saline 1 hour. If there is hypotension, like systolic blood pressure is less than 90, you have to give more quickly. Okay, and from second bag and onward, you have to give potassium. So 40 millimolar of potassium with normal saline you need to give. So we need 2 cannula in 2 hands. Possibly if you can do the large bore cannula, one for the fluid, another for the insulin. So key management is you need to give IV fluid, insulin, potassium, and treat precipitants. Sometimes you need to give broad spectrum antibiotic if there is any infection. So these are the main treatment lines. Okay, so how you give the IV fluid. So if there is any heart failure or kidney disease or respiratory failure, you can give slow fluid. So as I said before, the total approximate loss of fluid is 6 liters. So you have to replace this fluid. It depends on the body weight. If your body weight is more, you need to give more fluid. So if a patient weighing like 100 kg, the fluid loss can be 10 to 12 liters. So 50% should be this loss is 50% from the intracellular and 50% from the extracellular fluid. So we need to replace the intracellular fluid with the glucose and extracellular fluid with normal saline. So first bag should be normal saline. Second bag and onward should be potassium with normal saline, 40 millimole bag. Okay. So these 1, 2, 2, 4, 4, 6, 8, 10 you can memorize as a phone number. It's a 1 hourly bag, and then 2 hourly bag, another 2 hourly bag, then another 4 hourly bag, another 4 hour, and 6 and 8, and then 8, 10 hourly bag you can do. So maximum you can give 6 liters in first 6 hours. That's the maximum you can give. So if the patient remain hypotensive despite this fluid resuscitation, you need to call the ITU. Okay, so you are replacing extracellular fluid with normal saline and replacing potassium as well. So how do you replace the intracellular fluid loss? So you need to give dextrose. When the capillary blood sugar is less than 14, you need to add 10% dextrose at 125 ml per hour in other hand. So one hand you need to give insulin, one hand you need to give the normal saline, and other hand you need to give insulin. You can give also the glucose with on the same hand. So we need 2 cannula at least, okay? So one for normal saline with potassium and another one for insulin with dextrose. So you don't have to stop normal saline to start 10% dextrose. So you need to add dextrose and normal saline together. You need to continue, okay? So if the blood sugar is less than 14, you need to add 10% dextrose at 125 ml per hour to avoid hypoglycemia, okay? And consider and to replace the intracellular fluid loss. So consider 4.5%, that means half strength normal saline if the sodium is more than 155 millimole per liter. Okay, so as I said before, maximum 6 liter fluid loss in 6 hours. So maximum fluid you can give in first 6 hours is 6 liter if there is no contraindication. If there is any contraindication like heart failure, you need to go slow. So if the patient is hypertensive despite fluid resuscitation, you need to call ITU, maybe he need to give some inotropes. So this is the same slide we have spoken already. Okay, how do you replace the potassium? Is very easy. So that's if the potassium, you need to check the VVG. If the potassium is 3.5 to 5.5, you need to give 40 millimole bag. If the potassium in VVG is more than 5.5, you don't have to give any potassium. You just have to give normal saline. Okay. So if the patient is anuric for like more than 3 hours, do not give potassium unless you check the VVG. Because of the AKI, the potassium could be very high, so you don't need to give potassium. If the patient is anuric, check VVG first and then replace the potassium, okay? And consider urethral catheterization, as I said before, if the patient is anuric, do the bladder scan and urethral catheter if the patient is anuric, okay? So we need to check potassium every 2 hours for first 6 hours. And ECG monitoring is essential if the rate of potassium chloride solution exceeds 10 millimole per hour. In CV line, you can give 40 millimole per hour, no problem, but in peripheral line, if you exceed more than that, it can cause thrombophlebitis. So the concentration should be like a bit less than the, the CV line one. Okay, so IV fluid we have given, potassium we have replaced, now insulin. So how do you replace the insulin? How do you give it? So you have to give IV insulin, not subcutaneous one. So if the patient is already taking subcutaneous insulin, you don't stop the basal insulin, like long-acting or intermediate-acting one. So don't stop Lantus, Levemir, Tresiba, Insulatard, Humulin I, or Insuman basal. You can stop the Novorapid or Actrapid, which is like short-acting one. You can stop that, but don't stop the long-acting one, okay? So you should continue the long-acting one. Some patient has got the type 1 diabetes, some patient has got their insulin pump, that is subcutaneous pump. So you should disconnect the pump until it's reviewed by a diabetic team. Discontinue metformin. In acute condition, we don't want to give any metformin to the patient, okay? If the patient is on metformin, stop the metformin. If there is any subcutaneous pump, disconnect the pump and continuous long-acting insulin. And if it is new diagnosis, you should consider giving a stat dose of long-acting insulin like Levemir or Lantus 10 to 15 or 16 unit stat. So we need to commence 0.1 unit kg per hour. So how do you make the syringe? So you need to take, so usually 1 ml contains 100 units. So if you take 0.5 ml in 49.5 ml normal saline with the 0.5 ml insulin, it contains 50 units of insulin. So in a syringe, you will get 1 ml, 1 unit insulin per ml. So that's fine. That's the fixed rate insulin infusion you can give. So 1 unit per ml, so 50 ml of syringe, you can give 1 unit kg per hour. That means if the patient's weight is like 70 kg, you can start with 7 ml per hour or 7 units per hour. Okay, so as I said, you have to treat the precipitant, so check for the infection or anything that can precipitate the DKA. So send cultures, urine MCS, sputum MCS, check the inflammatory marker, X-ray for consolidation, and start broad spectrum antibiotic if it is appropriate. So CRP could be high because DKA is a pro-inflammatory condition. So you need to check for the other sign of infection as well. So sometimes the patient presented with abdominal pain, so you need to check the amylase as well for acute pancreatitis. So amylase could be a bit high due to DKA as well. So you need to be very careful. Okay, so we need to do the VT, VT profile, and then after that, sometimes you consider full anticoagulation, because if the patient having hyperosmolar condition is also thrombotic, so we need to consider prophylactic, or if he is hyperosmolar, we can give full anticoagulation as well. Bicarbonate therapy, we don't actually give bicarbonate in DKA, so because the evidence of benefit is lacking and the role is controversial unless there is renal acidosis, and the pH, if the pH is less than 6.9 and there's a renal component there like AKI and lactate is normal, you can give a bit of them, but the role is still controversial, so better to avoid it. So investigation, so if you replace if you give fluid and insulin and glucose together, it will lower the magnesium as well, because of the hypokalemia. Insulin causes hypomagnesium as well. So you need to check the magnesium and replace it. So you can do other tests like the troponin and amylase, CAP swabs as indicated. Check the ECG, because you're replacing potassium. You can take see any sign of hyperkalemia or something, or hypokalemia as well. So what you need to monitor? So you need to monitor news hourly, and then you need to monitor blood sugar and ketone every 30 minutes to 1 hour. You need to repeat the VBG at hour 1, hour 2, and then every 2 hourly for 6 hours. And you need to check electrolyte every 4 hours. This is very important. So what do we expect when we start IV insulin, IV fluid, and replacing potassium? So we expect biochemically there is reduction of glucose 3 millimole per hour, reduction of ketone 0.5 millimole per hour, and increase in bicarbonate 3 millimole per hour. These are our expectation. So we will check that if it is not there, if it is not improving, then what we can do, we can check the line first. If the fluid is going, sometimes cannula is tissued, we need to check the cannula. Sometimes pump is not working, you need to check the pump. If the pumping is working correctly, no buzzing or no signal there, or maybe if it is correctly going there, no cannula is inside the vein, then you need to increase the insulin by 1 to 3 units per hour. This is called FRII, that means fixed rate insulin infusion. So we use fixed rate insulin infusion because we are giving fixed rate like 7 despite the blood sugar or something like that. So we need to increase it if these criteria are not met, like if the blood glucose is not decreasing by 3 millimole per hour, or ketone is not reducing, or bicarbonate is not increasing. Okay? So clinically we need to check the vitals, like blood pressure is stable or not, volume status, like the patient is still dehydrated or fluid overloaded. We need to check that. If the patient is able to drink or eat, if he's having persistent vomiting, we need to give NG tube and see how it goes from there. Prescribe some antiemetic if required. Check urine output. It should be 0.5 ml per kg per hour, maybe like more than 50 ml per hour is adequate, I guess. So do the catheter if there is no urine output. Check GCS. If the sudden reduction of GCS, you need to do the CT head to rule out the cerebral edema. It's very common in young children, not common in adults. So what are the complications of DKA? As I said, AKI, renal failure. So ARDS can happen. We need to check the ABG and do the PO2 and FiO2 ratio to make the diagnosis with the X-ray. And sometimes cerebral edema, fluid overload, hypokalemia. These are the complications. So how do you know that the DKA has resolved? So these are the exit criteria. So blood ketone should be less than 0.6 millimole per liter, and bicarbonate is more than 15, venous pH is more than 7.3. If the criteria is met, if the patient is able to drink, consider switching to subcutaneous insulin from fixed rate insulin. So if the patient is unable to drink, then you can switch to VRII, that means variable rate insulin infusion. So that's also called sliding scale, who work in the, the hospital wards, we use the variable rate, that means the sliding scale. So to continue basal insulin, as I said before, from the very beginning, and stop the subcutaneous pump unless reviewed by the diabetic team. Okay, so these are the exit criteria or resolution of DKA. Ketone less than 0.6, bicarbonate more than 15, and venous pH is more than 7.3. Okay, so we need to ask the diabetic team to see the patient. So usually it's done within 24 hours. So they will ask if the HbA1c done. So if you do the HbA1c, it will give you the control of glucose like within 2 to 3 months. So it's better if it's not done in 3 months, you need to repeat the HbA1c before you discuss with the diabetic team. They may maybe ask to do it. So if there's a confusion, is it type 1 or type 2, they will ask some funny tests like glutamic acid decarboxylate, C-peptide, and islet acid antibody as well. So if the C-peptide is low and islet acid antibody positive, chat positive, that means it's likely to have type 1 diabetes. So we need community follow-up and conversion of subcutaneous insulin as well, as I said. So the most important thing is, so maintain 30 minutes IV insulin after you start the bolus insulin dose. So if you give Novorapid, like short-acting one, like 80 units before the meal, so you can give 80 units first, and then after 30 minutes, you need to stop the pump. So don't stop the pump first and then start the insulin. So you need to give subcutaneous insulin. In 30 minutes, it will go into the blood, and the half-life of IV insulin is very low, it's like 5 minutes. So you have to give subcutaneous insulin first, and then after 30 minutes, you can stop the infusion, the IV pump. So these are the system how you can start the subcutaneous insulin. There's a basal and bolus regimen. So the insulin secretion in the body normally is like in every hour is a basal secretion is like 1 unit per hour, and then with every meal it like 80 unit per hour, so like 40 unit per hour. So if you calculate the total daily dose, it's 0.5 to 0.8 units per kg unit per day. So it's a reasonable start. You can calculate the dose by calculating from the body weight, and then 50% you can do it as bolus, and 50% you can give as basal divided by 3 or 2. So it depends on what type of insulin you are giving. So these are the calculation you need to use to diagnose DKA. So osmolarity, you can calculate it by sodium into 2, glucose and urea all in millimole. Normal value is 280 to 296. You can check the anion gap because it causes high anion gap acidosis. Sodium minus chloride plus bicarbonate. Normal value is like 10 to 12. It is more than that, is high anion gap acidosis. And the other causes of high anion gap acidosis is renal acidosis, alcohol poisoning, methanol, or lactic acidosis. And you need to calculate the osmolar gap sometimes if in case of methanol poisoning. So measure the osmolarity, and you need to calculate the osmolarity, and if there is a difference, big difference more than 6, it is due to other poisons like methanol or something. Okay, in summary, how you manage the diabetes. Number 1, from diagnosis, from VVG, capillary blood sugar, and ketone. So ketone 3 or more in VVG, pH is less than 7.3, and bicarb is less than 15, and glucose is 11.1 or more. This is a diagnosis. How you treat? IV fluid, rapid IV fluid, maximum you can give 6 liters in 6 hours. You need to give insulin like 0.1 unit per kg body weight per hour, replace the potassium, and treat the precipitant and VD prophylaxis. So call ITU if they meet the criteria. If there is any indication for ITU, call the ITU, call diabetic team to see the patient, and follow the paper protocol and closely monitor. So I don't know, you are familiar with this paper protocol. If you have a look, you'll get the chance to see how it's managed. So if you can take and then have a look at the paper protocol, you'll see it's very easy to manage. Okay, so there's a quiz, easy, very easy. You can see it's a 90-year-old gentleman came to us with the altered mental status, with polyuria, like osmotic symptoms, weight loss, blood pressure, 92/65. So VBG, you can see pH is 7.21. That means it's less than 7.3. Bicarb is 12, potassium is 5, and blood sugar is 21, ketone 4.5. So what's the diagnosis? It's DKA diagnosis, very easy, quick, DKA. Okay, so another one, a bit hypotensive, you can see. So the blood pressure is 85/65. So when you want to give fluid, you have to give more quickly. That means first liter over 15 to 20 minutes, right? Okay, so you see pH is 7.11, it's a bit severe, right? Bicarb is 10, potassium 4.4, and glucose 21, ketone 5. So it's a bit severe DKA, I can see. Okay, so let's see the management plan, the monitoring. So we start treatment at 9 a.m. It will be very interesting if you see. So blood sugar was, you see here is blood sugar is 21, right? So ketone was 5, bicarbonate 10, venous pH is 7.11. So I need answer from you guys. Okay, so potassium is 4.4. So we start 6 units per hour. That means maybe his weight is like 60 kg. So we start 60 units per hour. We have given the fluid, first bag over 1 hour. He is hypotensive, less than 90. So we have given first bag over like 15 to 20 minutes, that's fine. Blood pressure stable. Okay, so after 1 hour, we check the blood sugar. It's a bit low than the previous one, so 18. So our target, lower the blood pressure, 3 millimole is fine. So it meets the criteria, that's all right. Ketone is 0.3, so should be reduced 0.3 per hour. So it's 4.2, that's fine already. Bicarb should be increased 3, so it's 13, that's fine. So venous pH is still same. And potassium is 5.6. So now tell me, what would be the choice of fluid? What fluid we would give? So normal saline. So we don't have to give any potassium containing like 40 millimole bag because the potassium is 5.6. Very nice, very good. Okay. So at 11 a.m. we can see blood sugar is 17, ketone is 4, bicarbonate is still 13, and venous pH is still 7.11, and potassium is 5.4. So what kind of fluid you want to give? If the potassium is 3.5 to 5.5, you will give 40 millimole bag. Okay? So 40 millimole bag. Tell me, what we're going to do about this blood sugar and bicarbonate. So it's supposed to reduce by 3 blood glucose from 21 to 18 is fine, but 18 to 17 is not good, right? So ketone is not reducing by 0.3, and then bicarb is not reducing from increasing from 13 to 16. So what you would do now? So we need to check if the insulin is going. So we need to check the pump, check the cannula, if it is tissued or not, and then you have to increase the insulin rate. So we are giving like 6 units per hour, so you have to increase it to 7, 8, or 9. So you can increase 1 to 3, okay? 1 to 3 units. So next step will be increase the insulin, fixed rate insulin infusion, okay? Fantastic. So at 1 p.m. we can see the blood sugar is now 12, and ketone is 3, bicarb is 17, pH improved 7.25, and potassium is 4. So tell me, what are you going to add with the fluid? So we have given normal saline with potassium. We already given the fixed rate insulin infusion. Do you want to give additional any fluid? Dextrose, fantastic. So you need to give 10% dextrose at 125 ml per hour in other hand, okay? So we need to continue the normal saline with potassium and the dextrose. Fantastic, well done, okay. So you can see at 4 p.m., blood sugar is now 12, ketone is 9.5, bicarbonate is 25, venous pH is 39, potassium is 4. Does it meet the exit criteria? So the exit criteria is the pH will be more than 7.3, number 1, bicarbonate will be more than 15, number 2, and the ketone will be less than 0.6. So 0.5 is less than 0.6, so it's fine. It meets the exit criteria. So what are you going to do? We're going to switch it to subcutaneous insulin. So we give the stat dose of subcutaneous insulin, and after 30 minutes, we are going to stop the IV infusion pump. If the patient is able to eat and drink. If he is not able to eat and drink, you need to continue the variable rate, the sliding scale. So how do you prescribe insulin sliding scale? There is a form there. You can see in the form, the paper form, there's written how to manage the sliding scale. I can show you later. Thank you very much. That's the end of the discussion, but I can show you the paper form. Just 1 minute, please. Okay, so this is one of the things I wanted to show. These are the criteria during discharge. So when you are going to discharge the patient, with the DKA, what you're going to do, if it's a new diagnosis of diabetes, we need to teach the patient the insulin technique and refer the patient to the community or district nurses, diabetic nurses. These are the questions you need to answer before you safely discharge the patient. And this is the form you need to be worried about, look for to manage the diabetes. This is the paper form you can see. So all the information I have shared with you are in these pages. You can find it any word, I guess. You can ask for the DKA protocol, they'll give you a paper form. So in the paper form, you can see there is a sliding scale there. Here, this part is the sliding scale. You see, in here is written that if the blood sugar is more than 14, you need to give 6 units per hour. If it is 12.1 to 14, you need to give 4. If it is 7.1 to 10, you need to give 2 units per hour. This is the sliding scale you need to start if the patient is not eating and drinking, okay? So you'll get all the information required in this paper form, so you can have it from any of the ward, especially in AU. If you pop into the AU, you can get a form and keep it with you, and then you can manage DKA more confidently. Okay, any question for me, please? Any question? No? Thank you very much. Thanks for patient hearing. Thank you. Thank you.